You are listening to the Neurocareers Doing the Impossible podcast with Dr. K, episode number 20. Dear Neurocareers podcast listeners, today we have an amazing guest from California, Dr. Caroline Schnakers. Dr. Schnaker will be talking to us about a fascinating field of the use of neurotechnology in patients with a traumatic brain injury and, in general, people with disorders of consciousness. This field is rapidly changing, and we discover more and more about what is happening when patients are in this unconscious state. So Dr. Schnakers will give us insight into this field. Thank you so much for listening and stay with us. Hello, Dr. Schnakers. Welcome.
Thank you. I'm glad to be here.
Thank you so much for being our guest. It's wonderful to have you here with us today. Can you please introduce yourself, tell us about your background and where you are joining us from? We have an international podcast with speakers from all over the world and different states in the United States. So tell us a little bit about where are you located.
Yes, thank you. Thank you for inviting me. So my name is Caroline Schnakers, as you said very well. Actually, not everyone can say my name correctly. I am the assistant director of the Research Institute at Casa Colina Hospital and Centers for Healthcare in Pomona, California. I also recently got an affiliation with the Department of Psychiatry at UCLA as a volunteer assistant clinical professor over there. So, I have been, living in a lot of places, but mainly in Belgium. And now for more than 10 years in California, I started at UCLA in the neurosurgery department. And then I got recruited by this wonderful hospital where I'm very happy right now and doing very good research.
Yes, and I know that you published a lot on your research topic. You are doing absolutely amazing work. Can you just briefly introduce what type of work are you doing?
Well, it's actually a long story because my career had different question of interest, I would say. So I started in the field interested in diagnosis in these patients simply because the treatment at that point was. So I started when I was 20 years old, like 22 years ago. There was not much that was developed for this patient treatment-wise. So it's not like we could be interested in that. So mostly my questions were really related about on diagnosis and trying to better understand how to improve the detection of signs of consciousness in patients who recover from a coma and transit to vegetative states, minimally conscious states, using different techniques. My main interest, I have to say, and I might be biased actually further in the conversation because I really love electrophysiology, even though, I would not represent myself or describe myself as a high expert, but I definitely have some expertise and using behavioral scale that clinician can use at the bedside, which of course can be implemented everywhere and is crucial for now. But I think, as you said, with neurotechnology developments, there is so much now that is implementable for clinician, and it will be more and more the case in the future. Just right now, I think the clinicians don't know what exists really. So it's not implemented, not because it's not there, but because they don't know it exists and it's possible. So it's our job now with clinical implementation field developing also to just make aware this clinician that this is possible and they should use that and how to use it. But this is not that easy. So for coming back to your original question, I got into the field interested in diagnosis. And I have to say in the past 10 years, there has been so much developments in terms of treatment. Of course, it's the beginning. So it's still baby steps, we'll say. But we start to have really a good development for treatment, and particularly with neuromodulation techniques being more and more developed, they start to be much more option and things that can be investigated, devices that can be investigated to see if they could actually help these patients to recover more quickly from a disorder of consciousness. So first, my question was diagnostic. And 10 years ago, I shifted slowly but surely towards treatment, we'll say.
Mm-hmm. Yeah, very interesting. And we will talk more about that. Maybe just couple of words for those who are not very familiar with the disorders of consciousness. Can you define what is that? And you also mentioned minimally conscious state, vegetative state. What is the difference between those states so that people who are not familiar would follow our conversation? And maybe also you can provide some clinical example just to showcase what is it.
Yeah, I actually will take a clinical case, a fictive one, if it's okay with you, just to illustrate the different state of consciousness. I think that might be easier for the listener. So imagine a mother leaving her daughter and husband from home. She's in a hurry. She's late. She is in her car. She's late for work. She's in an important meeting, and she's just trying to get into traffic, which is very stressful for her. She, at that point in time, has her phone in her bag, and she absolutely has to call a colleague to let her know that she will be late a few minutes for the meetings. And reaching the bag in her mobile phone, she actually, for just a few seconds, lost the vision of the traffic, and she just bent, tried to reach her purse and take something inside. She think that it's okay, but actually a car that is coming on perpendicular to her is hitting her from where she is on her side. T-bone, as we say. So the car accident is violent. She gets very severe bleeding in her head, and she's transported in an emergency at the hospital. She's unconscious at the time. They arrive at the hospital and say, Glasgow coma scale 3. And she's just not responsive at all. And so they transport her. They try to make sure that the blood is taken care of, and they do a good job. They stabilize her, and they decide to put her in intensive care for 2 weeks. During that time, her daughter and her husband come every day and stay with her. And at some point, few days after injury, the doctor come and say, well, okay, so she has been in artificial coma till now, because we have been doing a very deep anesthetic for her to, and her brain to recover a bit and stabilize, having her vital signs stabilize, which is really the first step. So everything goes well. She will be in the few following days lightened on her anesthetics, and we'll see if she waken up. It's done, and after 2 days, she starts to open her eyes, and that's just so much relief for the family. They feel like she's there, she's opening her eyes. Look, she's conscious now. And the doctor come and explain that, yeah, no, it's not because your, mother or your wife is opening her eyes that she actually is conscious. It's just a good sign that the brain is, or reptilian part of the brain is recovering, but it's not yet sign that she's recovering consciousness. And the family, it's hard for them to understand, because when they call her, she open wide her eyes and they say, look, she's reacting. And the doctors say, yeah, and these unfortunately are reflexes, but we'll see. Maybe in a few days she will actually respond. After a week, they start to see that she actually sometimes look at them. And her daughter, who is just in front of her and moving slowly, just start to see that she actually follows. So very excited, she just get out and lets the nurse know about it, and the nurse come and observe exactly that. And she says, this is fantastic. It means that she starts to get the first signs of consciousness there. She starts not to be in a vegetative state anymore, where you have no signs of consciousness, just awake and having reflexive activity, but you start to show some oriented movement now. She starts to show some oriented movement now. So she's in a minimally conscious state. This is good news. This is great. And plus, the signs are coming very early after this traumatic brain injury, very severe brain injury. So that's a good sign. They decide, because she's stable enough to do actually a hole in her neck, because now she's really stable enough to breathe on her own. And so they decide to transfer her to acute rehab. And over there, in the following few weeks, she started to do very well. She started to actually move more. When we ask her to do something, she does it. Not all the time, but she does it at least more than once. And after a while, she starts to show that she wants to verbalize. So they start to try to put some a speaking valve on her tracheostomy, which is the hole in her neck. And so she actually start to say some words, first groaning, but very soon after vocalizations and type of and then mom. And then she starts actually to say a few words that are very simple to say, but she starts there. And there, her recovery is actually getting faster and faster. And at some point, she's able to use objects around her and maybe take a cup and drink from it. And then that marks actually her emerging from disorder of consciousness. It's not the end of the story at all, because when you have a severe acquired brain injury, it's chronic disease. It's all your life. You get some very severe deficits, working memory. So the trying to, put your thought together, try to plan the day, things like that are very difficult for these patients. They're very impulsive, and sometimes they're described as being different than before, not knowing, this person, and the family has to rediscover who is their mother, who is their wife. And that might take time sometimes. But this is what it is, disorder of consciousness. It's just a spectrum on which these patients are after a severe brain injury.
A very nice illustration. Thank you very much. It is a very severe disorder. Even listening to your story, it's difficult to think that people can be injured that way and have so much suffering. My question is, what brought you to this field and what helps you to still work for so many years? Can you tell more about it? Where is this passion is coming from?
It's interesting. It's just a call. Really, I remember having to choose a topic for my dissertation. And in Belgium, at least at the time, 20 years ago, I used to do that very early. So you were 19 when you were starting to think about your dissertation, and 20 when you were starting. And I remember seeing a title that was trying to develop diagnostic tool for assessing consciousness in severe brain injuries. And I was fascinated. And I just felt that this is what I wanted to do. And I asked for having that topic, and I actually felt so strong about it that I went to my supervisor at the time, was Steve Majoris, who was in the Department of Psychology, or was at the time in the Department of Psychology and Neuropsychology at the University of Liège in Belgium. And I told him, I'm the one. you have to choose me for that topic. I was very impressed that I was that, categoric about it. And so he decided to take me. And yeah, I just kept that as a passion. I felt it was the right thing for me to do.
Yes, we have actually some podcast speakers who are talking about this, that it's so important to be passionate about the topic you choose, because it's not an easy work to be a scientist, and you need to dedicate a lot of time to this work, and the time that you are paid for and not paid for, so, and go through many difficulties, and it's so important to have that passion. So thank you for telling our listeners about this. You were talking about developing the diagnostic tool. I know that the development is still underway, so the diagnostics is changing. And with the change of the diagnostic tools, many misconceptions about the disorders of consciousness are changing as well. Can you tell what are the most common misconceptions about the disorders of consciousness, and then we already will talk about how it is changing and what helps to change. But let's start first of all with those misconceptions.
The Sleeping Beauty. So the fact that, that I remember when I was a kid and watching the soap opera, you would have this person in a coma, beautifully dressed and having like this makeup on and just sleeping pretty much. And this is just not what it is. The crude reality is that person is badly injured, that they often have their hair shaved because there are some scars and things neurosurgery that occurred sometimes to remove the blood that they had in the brain. And so that, just caused a lot of pressure inside their brain and on the brain that could be even more destructive. So they have to drain it. And it's just not true. And I think that, just realizing that is not true is also preparing the family and people realistically, the surrounding, to see that person, because this is shocking to see your close one in that state, and they're just having cables everywhere for them to just go through their journey, medically speaking. So as I told you, you have most of the time, a hole in your neck to allow you to breathe more easily. And that also is something that is very hard to see in your close relative. And there's most of the time also gastrostomy that are done for these patients to be fed, because they cannot be fed by the mouth. So you have actually to do a hole in the stomach to make it go through. And all that, having that information get through the family before they see the patient is very important. I think now with the shows like ER or what is the other one, like Dr. House, but it was like Grey's Anatomy. I think that really led to have a better understanding of this reality and crude reality. I think that another misconception is that there is only coma, and this is changing. People start to know about vegetative states with very famous cases like Terry Schiavo and other cases through Europe. Really help, I think, media to carry that information to the public, and the public start to know now that it's not only coma. It's not like you are in coma and then you're not. It's actually really a spectrum, and I think this is also is carried through the media more accurately now, fortunately. Another thing is maybe the diagnosis, detection of consciousness are not that easy to do. These patients have sometimes a lot of difficulty to just have enough energy to respond. So these responses sometimes are very subtle. So you need to really develop a very high expertise to just detect the signs and know what sign is a reflex and what sign is not.
Thank you so much. And you already mentioned diagnosis. In one of your talks, I watched your YouTube videos. You were mentioning misdiagnosis, and it's published as well in a number of papers. So there is a high percentage of people misdiagnosed in unconscious state. Can you tell a little bit more about that?
Yeah, no, totally. So that's, one of my most important paper. That was in the beginning of my career. I just realized that really you have to have an expertise to detect signs of consciousness, and you really have to be in touch with the literature. And there is a gap between what we know in research as an expert and what the clinician know through their learning and through academic learning, unfortunately, and their training. There is a really huge gap. And so I thought, okay, so let me see if actually, if I go to all the different centers there is in Belgium, if I do an assessment with a very sensitive scale, which is the Coma Recovery Scale Revised, which is now used really worldwide for these patients, rather in a chronic stage, but it's very well known. And I went to the bedside of these patients, and I just realized that actually there is 40% of misdiagnosis if you rely only on the clinical consensus. So that was a team of clinicians agreeing on a diagnosis, which is incredible to think that me coming once with a scale that is very sensitive and my set of expertise, which was not that big at that time, because remember, it was the beginning of my career. I actually was able to detect signs of consciousness in one session, and they were not able to do that, even though they were seeing the patient every day. So that just illustrates how difficult detecting signs of consciousness is. It's not impossible, but you have to know not only the criteria or the new criteria, because they are changing sometime from, every 5 years, so every decade for sure. And so you have to keep yourself updated. From then, I really started to be very interested in developing additional tool for clinicians for helping them to detect signs of consciousness. But yeah, 40% of misdiagnosis of people you are thinking were not conscious while they were.
Yeah, that's a huge number, and it makes a difference in how people are treated, what are the possible prognosis, even the effect on the whole their family. So there are so many consequences of that. I got curious when you were talking about this. What helped you to become an expert in this type of diagnosis? You mentioned that it was a sensitive scale, that's one thing, but also your skills as a specialist. So what helped you to be such a good specialist?
Well, the team in which I was, the Coma Science Group, who was led by Stephen Lores, who is led by Olivia Guthrie now with Aurore Thibault, really helped me. Just having Stephen, Professor Lores, to help me understand what is the disorder of consciousness and just help me in my first step, just understanding how to assess these patients, was just a huge help. And the Coma Science Group, I have to say, is one of the highest expertise team in the world. So, my promoter, I had the luck to start with one of the hugest VIP, if you will, in the field. And so that, of course, helped me big time to develop that expertise through the years. And just, of course, working with international collaborator, they were just the brightest mind of their time, and just developed that through the years.
So it also shows the importance of this peer-to-peer learning and mentorship and guidance from professionals who already are well established in the field. So I just want to emphasize it for those students who are starting, who are doing their graduate and postgraduate research, that is really very, very important. Thank you so much for talking about this. We already mentioned that there is a big change.
Can I just add something? don't hesitate to read about these phenomenon or rather topic that you're interested in, and don't hesitate to see who publish in good journals, on PubMed. PubMed. There is so much that you can find on the topic you're interested in. And often, you can have contact information of authors, the first author or the last author. Do not hesitate to contact them. Do not hesitate to send an email and say, hey, I'm interested in that topic. I would like to discuss with you for a few minutes. They might not answer, but you have nothing to lose in at least contacting them. Because if you do so, then you will be directly in touch with people that know what they're talking about and are very high expert. And really, if you can get to these teams, it will be a huge advantage for you to start in the field, because you will be getting access to a lot of knowledge right away on the topic you're interested in.
Yeah, thank you so much. Thank you so much for this advice. I'm sure our listeners will appreciate it. We talked that there is a big change happening in the field of detecting and diagnosing disorders of consciousness. Can you tell more what is going on, how this change is facilitated, what is changing? And after that, we will talk probably more about the involvement of neurotechnology in this process. So if you can comment on that.
Yes, of course. Well, actually, it's related to neurotechnology, really,
Okay.
because sorry for that. But I will probably talk about it right away. So
Yes.
I have to say, when you look at the guidelines that have been published recently by the American Academy of Neurology and the European Academy of Neurology, there is a lot of interest in just implementing, particularly European Academy of Neurology, a lot of interest in implementing neurotechnology in the assessment and detection of consciousness, and particularly of neuroimaging, but also of electrophysiology, which is much more implementable because, with EEG, you can go on the bedside and put electrodes on the head of the patient. It's way more easier. It's way easier, than transporting them to the fMRI machine and make sure they don't move, which, sometimes it's just not possible because the patient do not listen. And when they start to be conscious, they're a little bit agitated. So it's quite a challenge. So EEG has definitely some advantages there. So definitely having more technique to diagnose it, for diagnosing these patients, using the brain, pretty much using the brain activity to just try to define if these patients are conscious or not. And then there are some indexes that I'm very excited about, but it's not really implementable for all setting. But there is the PCI, perturbational complex index, that is actually very, I think it will be the most likely one of the most used tool when they will be able to figure out how to implement that in all setting. But that might actually be the next technology that will help clinician to define just with a number if the patient is conscious or not, in parallel to behavioral assessment, of course. We'll not get rid of that. There is that. And definitely, having the biggest development was to actually see that publication in 2006 of Cambridge University about that case of a vegetative patient who was able to imagine playing tennis using neuroimaging. And that was big. And at the time, I didn't know how to receive that news. It was I was a bit in shock, I have to say. I discussed with a colleague of mine, Melanie Bolly, who was working in the Coma Science group with me, she's one of the brightest mind I know. And she was telling me, yeah, I'm working with Adrian Owen on that project. I said, what project? I said, yeah, we're using fMRI, and they tried to ask them to do things like imagine playing tennis in the scanner. And I laughed. And I said, come on, really? I say, yeah, and they want to do that in vegetative patients. I say, really? What do you want to find? It's just not possible. Say, well, I don't know, but it looks interesting. And so she actually participated to that study. And after, I was like, yeah, I'm sorry, you're right. I say, yeah, I know, right? That's incredible. But yeah, they were able to show that patient. And then afterwards, through the years, it has been exponential. And now there is really a discussion about, because of these cases that are covered awareness, patient with covered awareness, there is a lot of discussion about implementing neuroimaging and electrophysiology systematically for diagnosing this patient, because we know that behavioral might not be enough for some of them. It looks like it's around 20% of patients in vegetative state that might actually be conscious using neuroimaging. In chronic patient, it's still undefined or not very well defined in acute, but it looks like it's very similar. So it's really very important to have this neurotechnology implemented, particularly in this field. And I often say, if it applies to severe brain injury, it will apply to moderate brain injury and other type of brain injury. So if we find anything that can be helpful for this population who has the last of everything, it's just very hard for them to recover, then we'll be most likely having some solution for less severe brain injuries. And so having that as a very fundamental change when you look at the diagnosis is one of the deepest transition that has been occurring in the clinical field. I think there is more and more clinicians that thinks about using fMRI and electrophysiology when they have a patient coming with a disorder of consciousness and they cannot find any signs of consciousness at the bedside. They start more and more to wonder how to implement this technique. It's still in a transition phase, I have to say, but it's really changing right now. Treatment-wise, I think that with the development of all this neuromodulation technique, like transcranial direct current stimulation, like transcranial magnetic stimulation, and more recent technique, which I have been collaborating on, such as low-intensity focused ultrasound pulsation, LIFE-UP, these techniques will really change the field, and it's already changing the field. Because they are non-invasive type, there is deep brain stimulation too, but it requests neurosurgery, and sometimes you don't want to use that in these patients that are already fragilized and can get infection very easily. And the development of these techniques is really changing fundamentally the field. It's more recent, but right now it's all over the place. Everyone is trying their own thing. In vagal nerve stimulation, there is also a lot of studies that are starting on that topic. So treatment and diagnosis have been changed in the beginning, and now because of these results and findings that the neuroscientists were able to found because of this neuroimaging and electrophysiology, now we have some neurocorrelates that, or at least some suspicion of which target in the brain is important for these patients to recover consciousness. And so that's the reason why we can treat this patient now, is because we have a better idea, thanks to the neuroscientists, we have a better idea of what is important for a patient to recover consciousness. We still not have a definite idea, but we have more ideas of how that all work.
Mm-hmm. Thank you so much. And with these neurotechnologies and electrophysiology, functional magnetic resonance imaging, all the information that those methodologies provide us, what do we know now about patients with the disorders of consciousness that we didn't know, let's say, 10 years ago?
Do you mean brain-wise, like the area of the brain, or?
The area of the brain and anything that can help us to diagnose and to treat them.
Yeah, I think that what we didn't know is that it could be possible to have a patient that is conscious to some point and not show any signs of consciousness at the bedside. I think that was absolutely crucial for the field to know. It has a different name. I actually published I'm the chair of the special interest group of disorder of consciousness of the International Brain Injury Association, with Nathan Sassler as co-chair with me. And we have published 2 papers which were meta-analysis. So meta-analysis is just you look at the literature, you look at what articles are important and have been well done, and you decide to extract some data from that and write a review about it, yes, but also with this extracted data, do further analysis to do like maybe a bigger analysis, because sometimes you have case reports, and a lot of these case reports together might be actually a bigger population to consider. And so your findings are a little bit more solid if you consider 50 of them instead of one at a time. So we have been doing that. And the first study was really to show that that phenomenon, that is finding a patient that responds to an active paradigm, so asking him to imagine playing tennis in a scanner while he's not showing any signs of consciousness at the bedside, is happening more frequently in patients that have a traumatic brain injury than in patients that do not have a traumatic brain injury. And that was actually the suspicion of a lot of investigators before, but they could not say because they didn't have enough patients in their sample. So having all this sample all together and just have kind of a overview of what, the profile of these patients who can do that specific task was helpful. And right now we are, even after 10 years, we didn't find a name for that. So we're still in the middle of a debate how to call it. There is a general umbrella, I would say, where we call it cognitive motor dissociation. And that just is the additional step for a clinician to have a name to call it when they discuss with their family about that phenomenon. But that was really one of the biggest changes. I think that other things, such as having a better understanding of how the brain works and how the thalamus, who is inside the brain, has a central role in the recovery of consciousness, but also how functional connectivity, the way all the areas are talking with each other, is very important, and actually dissociate patients that are not conscious from patients that are conscious. There is also that not only it's important to have a functionality or connectivity between very close area, but the most difficult part is actually when the area are a little bit further. So, for example, frontoparietal disconnection is very typical in these patients. But this again is changing. So there is a new neuroscientist finding that will probably lead us in a different direction in the future. But this is the understanding that functional connectivity is very important for these patients, and that thalamus might have a central role in the recovery of consciousness.
Yeah, thank you so much. And definitely with the new developments, there are new challenges that are coming up. What are the main challenges that are still present or maybe becoming more prominent as this field is changing?
So reimbursement, to make sure that these patients are really, well taken care of and have all this science implemented. I think at least in US, and that might to less extent apply to other part of the world. But in US, this is really like a big, unfortunately, a big issue. These patients most of the time are for 2 weeks in a rehabilitation unit. They don't evolve too fast or fast enough. And so they're sent to nursing home right away, where just family wait for a spontaneous recovery to occur because nothing is really done to their relative through that time. And that's very hard to really watch. And I think that's the reason why also I want to be involved in clinical management of these patients much more in the future. I really want to develop much more tool because now I think it's possible. As I told you, there is so much finding and understanding of the brain and how consciousness recovery can work in the brain or works in the brain. And so that helps. And we're at a stage where I don't believe anymore we can say, we don't know enough, we have to do more. Yeah, of course, you have to do more always. Always you have to do more to understand better about a phenomenon. But I think that now we gather enough information at least to try to develop techniques and develop treatment or therapeutic option that might work for these patients. And it's what we are doing with low-intensity focused ultrasound in collaboration with UCLA and Professor Monti, who actually was the one developing that technique with the Department of Psychiatry and Sasha Bistritsky. So, yeah, I think that, this is just very difficult to implement this technique right now because the reimbursement and all the codes, that are used for having billing and have this insurance company reimburse are just not there. Are just not there. So you just can't do it. So it's very hard. I think it will change. It will change in probably in the following decade. Unfortunately, yes, I'm not talking in years, but rather in 10 years, for sure, because there has been so much technological development in the last few years that they will have no other possibility than to develop codes for billing for clinician for these techniques, because they will be all over the place. And so they will have to regulate. They will have to. And they're already trying right now. There are a few techniques that are deep brain stimulation is one of them. There is another invasive one that is spinal cord, spinal surgery, and spinal implants that they use to sometimes monitor back pain. But so that's on the way, but it's definitely not happening right now. So I see a lot of unfortunate cases where the family do not have the resources. And so they don't know where to go. They're lost and they don't have much. And the expertise in the centers where they are is just not there. They don't know what to do with this patient. And so they just let them be. It's changing again. It's really changing, but it's really a gap. It's a big gap that really it was with the development of implementation sciences. There has been much more tool that you can use to actually implement this research finding in the clinical setting. And I think this is also very important. But yes, this is the main issue, is to bring what we found in research to clinicians and give them more option when they are managing or taking care, rather, of these patients.
Yes, thank you very much for mentioning that. It reminded me some talks of Professor Hans Beerbaumer from Germany.
Beerbaumer, yes.
He was mentioning this issue in Europe. Maybe you know what's happening in Europe as well. Are there any differences between this reimbursement in the States and Europe? Because you worked in Belgium for quite some time and probably you still have connection to what's going on.
Yeah. In Europe, I think it's not a problem of reimbursement. I think in Europe, it's just access to technology and the expense, the cost. It's just that, and not knowing. I think the common elements between US and Europe and other part of the world is really, as I told you, the gap of knowledge that experts have that is not brought to the clinician. And one of the reasons is really the clinical training and just the curriculum, the academic curriculum do not include this topic right now. So how do you want to have people taking care of these patients with the an appropriate knowledge of the topic if they're not trained, they're not exposed to it at all when they are at school. So this should be changed in the future. But yeah, in Europe, I really think that it's a question of cost and access to technology rather than anything else. In US, it's not that. I mean, it's a little bit that, of course, but it's more reimbursement for the family because everything is so expensive.
Yeah, thank you. The challenges are not only in the field, but also when researchers are trying new things and developing new methodologies. What was challenging for you on your way to doing research and finding new information about this field?
Well, funding source. I mean, this is an orphan disease and not everyone is interested in the topic. I think it's changing right now with some initiatives such as the Curing Coma campaign that has developed a huge international network. The group actually was coming from the Neurocritical Care Society, NCS, and it was just a movement in the beginning that just translated worldwide. And now they actually have their second edition of the World Coma Day on the 22nd of March. I think that most of the time foundation and governmental funding are sensitive to the topic if they can generalize the findings to something else. And that's the challenge, is to just, as I told you before, just carry the importance of that field. Because if you find anything for diagnosis purpose, for treatment purpose that works for them, it will work for less severe injury. It will work for moderate traumatic brain injury. It will work for moderate stroke. It will work for other things. But the problem is that for the longest time, just people have seen it as, well, it's just a few percentage of a few percentage. So why would we care about that orphan disease? And the truth is, yes, it's a small percentage of a small percentage, but it's so severe that if we find anything that works for them, that will work for the rest of the group. So this is the set of mind that you have to be in and be good enough to carry as an information to the funding source. But it's not always easy at all, I have to say. So this is, I would say, the main issues really to find the funding.
Yeah. And this issue very often comes up, but I hope that you will finding for such an amazing work you are doing.
I have been lucky till now, but I know it's not easy for everyone. So.
Yes, that's true. And I'm very curious, what was the most unexpected finding through all your research career that you've made when studying patients with disorders of consciousness?
Well, I would say actually the last, series of work I have been doing with Professor Monti at UCLA, which is the low-intensity focused ultrasound pulsation, I really was thrown into neuromodulation a few years ago with TMS and transcranial magnetic stimulation and TDCS, and I got just very interested in that. And then when I heard about that technique, I thought, well, that would be interested, but I didn't have any expectation. And so now I really see how this can impact patients. And I'm very excited about this, but you have to keep in mind that's just a step. So, as a scientist, you get excited for every small thing you find. So put in context, for clinician, it might be, that's good. That's good, going in the right direction. That's not transcendent, but it's good. But I think that this treatment has a lot of potential. And we have been doing a series of studies at UCLA and then now at Casa Colina, who allowed us to have patients for 10 days to actually have a good follow-up and try to see them well at baseline and using multimodal techniques, EEG, MRI, PET scan, everything before and after treatment and see what changes. And it's just extremely interesting. So right now we're trying to think about having the next step, which will be having a sham to see, placebo versus treatment, if that stands out. So I don't want to be too excited about it. But it definitely, if the findings are replicated with a sham, this will be wonderful. It will be an additional, don't get me wrong. I'm not saying it will be, the only treatment. I think that TDCS and any other neuromodulation technique that will show in the future some effect will be just a set of options that clinician will be able to use for treating appropriately their patient and maybe a little bit earlier than now. Because right now we have patients that are chronic after several years they come to us, I imagine. So family is quite desperate. It's really their last resort in a way. So I would say that's maybe not the most striking, but I think that per se, it's the most important one. Because when I'm a clinical scientist. I do not define myself as a neuroscientist. I'm someone who is interested in helping clinicians to take care of their patients. And so to me, this is an exciting time because we finally can be in a position where we really concretely could help clinicians. So that's very, very valuable to me to be living this time where I'm not only observing them and saying, yeah, they're in vegetative states and what do you do with that, right? So now we are in a position where we really can help them. And that's awesome. That's really wonderful.
Yes, I absolutely share your excitement about that. And I'm very curious, what do you think about the time, let's say 10 or 20 years from now? Where do you see the neurotechnology and how it can help clinicians with the diagnosis and with the treatment of patients with the disorders of consciousness?
I think that if efforts on implementation and just trying to decrease the gap between what we know in the field and what the clinician know. Having healthcare taken seriously this technique and creating codes that clinician can use to treat their patients safely, of course. To have this technique so much available that the costs to buy them diminish substantially, that will actually transform the field in the decades that come. And I think that will happen because there's so much effort right now that are done in this direction. Having much more study done, having companies involved in developing, which was not the case before. I mean, when I started, it was like evil, oh no, I cannot be involved with a company, terrible people, they want to make money on my back. But it's not, it's not some, of course, but it's not all the time the case. And you really have to, I think that now there is more and more funding source that actually promote that partnership between scientists and technological developers that try to just do a good product, but also based on evidence. And that's what is incredible this time. It is that we are an evidence-based era. We are interested in having evidence. And based on evidence, you can make treatment work. And if even companies are interested in evidence-based, then in the future, we'll be able to have good products for clinician to be used, as long as they are not expensive. If they're produced like at a large scale, and it will be the case in the future, I'm sure that it will be really more accessible. And so that point. Patient will be treated not only better, but also earlier when you can really do more for their recovery.
Yeah. That's a beautiful future. I hope it will come sooner than later. And in that future, where do you see yourself? What are your future plans with your research and the work you're doing?
Well, treatments, improving the clinical management of these patients. I think that one of the thing that I'm very interested in also is just not only improving their consciousness, because I don't want them to just have a better mind, but not a functional body. And a lot of these patients have a lot of motor impairments, spasticity, which is just the contractures of the muscle that goes to some extreme level that you cannot move anymore. And a lot of these patients develop that sometime quickly, sometime not, and we don't understand very well why. And so I think that might actually be another topic I'm very interested in helping in, even though I don't have much expertise like a PMR doctor would have or a PT, a physical therapist would have. But I'm interested in trying some new, to develop some new option to improve motor function in these patients, maybe with actually neuromodulation, for example.
Absolutely. And this, in general, field of neurorehabilitation, yes, physical therapists adding to that field a lot. And we had one of the podcasts with the neurorehabilitation specialists. Maybe I can connect you if you would like at some point.
Oh, yes, totally.
Yeah, so...
Thank you. That would be great.
Thank you so much. And now, if our listeners, let's say young scientists or scientists that want to change their path of the career into this field and they want to follow your footsteps, what would be your suggestions how to get onto this path of working and helping people with the disorders of consciousness and maybe using neurotechnology as well in this type of research?
Well, I mean, it's a very multidisciplinary field. You can be a neuroscientist that help clinicians indirectly. You can be in the medical field, a PM&R doctor, neurologist, psychiatrist even, actually, physical therapists, occupational therapists, speech therapists. All this is valuable member of the scientific community, and of course doing a PhD is very important. And again, what I said before stands for answering your question, is that if you are interested, go on PubMed, try to find articles or reviews that were published recently, and try to see who published, and try to be in contact with these people, these experts, and try to maybe meet them. I mean, they will put you in contact. Maybe if they are too far, they will put you in contact with someone nearby. But this is the first thing, is really to reach out, to go to conferences about brain injury. You might actually connect more quickly with these experts. And there's so much now option for listener to actually be in contact with these experts. People are in touch. They are within a network and much more connected than ever before. So definitely a lot of option there. And I'm sure that, the next generation will be providing much more neurotechnological advancements than what we have been doing till now. It's just exponential now, tell you the truth. I know that you had Christoph Guger, with Brain Computer, developed Mind Beagle, which is just an amazing product that I really love very much. And I think that might actually help patients a lot in the future. Just again, neuroscientists hand in hand with clinical scientists. This is like the right way to look at it. Like everyone hand in hand and trying to progress together. Of course, there is competition. This is science, but not too much. Just the right amount.
Yes, absolutely. I agree. And multidisciplinary teams, this is the key, I think, moving forward in general in science, especially neurotechnology related. Our podcast is called Neurocareers Doing the Impossible. Yes, and we can see that what wasn't impossible yesterday is possible today. How do you think that our listeners who are just starting doing things in science and neuroscience, how they can achieve what seems to be impossible? What would be your advice?
Think out of the box. It's not always easy, but you think out of the box. I think that the first step is to know well the literature. And if you know well the literature, you can come with questions and very interesting questions. But don't hesitate to think out of the box. This is precious because that actually just injects new ideas. And if you feel that this is supported in the literature, might be a little bit of a crazy idea, but might actually work, just go for it.
So not to be afraid of crazy ideas, but of course, check it. Not too crazy.
Okay, but
okay.
Crazy enough.
Thank you so much. And one more question: if somebody wants to contact you or to find more information about you, how they can do it, if you can tell our listeners, and we also will add this information to our podcast notes. And anything else, maybe some upcoming events or any publications you want to mention, it's a good time to do this.
Yeah, so, if they want to find me, they can contact me through the website of Casa Colina Hospital and Centers for Healthcare. If you type just Casa Colina, Pomona, California, no worry, you will find a website right away. So you can definitely, there's an area for question and you can ask a question, and I systematically have those questions transferred to me. So you can definitely take contact with me through that. And then search for Disorder of Consciousness, Special Interest Group, International Brain Injury Association. We are doing some webinar quarterly starting November 2nd. We'll have our first one talking about the few research we have done in parallel to the Dogma project, which is a project in Europe gathering a few experts in the field working on diagnosis, prognosis, and treatment in these patients. And then we organize a few conferences. But if you actually get in contact with that group, you will be in contact with an international network of experts in the field. And that definitely is a good way to start.
Yeah, that's amazing. Thank you so much, Dr. Schnakers. It has been a great pleasure talking to you. Our listeners will very much appreciate that. And I wish you all possible success in your research and helping clinicians and helping so many patients. So thank you.
Thank you.